Hello everyone. Today I'll be talking to you regarding sarcoidosis. Okay. So, what is sarcoidosis? It is a non-caseating, very important point you should underline, granulomatous disease. Okay. So, before I really go into the topic of sarcoidosis, you got to know a lot of basic concept. What is caseation, what is non-caseation, what is granuloma, and that is the bottleneck for 99% students are not clear about these basic concepts. So first we'll consolidate our basic and then I'll come to the subject of sarcoidosis. So what I told you just now, it's a granulomatous disease. So let's see what is a granuloma, basic concepts. So whenever we talk about granuloma in pathology, is a organized collection of macrophages. So the key word to remember is macrophages. Okay. Well, there is an accumulation of macrophages, but one more thing, there is an organized way of collection. It has a special meaning of organized collection. What the meaning I'll be discussing soon. But as of now, in this particular slide, there are only two keywords. One is non-caseating and second is granuloma is macrophages. Only two keywords. Next. Now, as I told you, sarcoidosis is a type of granulomatous disease. Now, let's see what is the meaning of, what's the definition of granulomatous inflammation. What is this? It is a chronic inflammation. Point to be noted. It's not a acute. Very, very important point you got to know, chronic. Okay. So now what happened is a chronic case. So suppose there is some pathogen enter the body. So our immune system, they attempt to isolate foreign substance, which they are not able to eliminate. Very, very important point. This we have to learn. Day-to-day example I give you, it is very often seen that a terrorist or a terrorist enter into a terrorist enter into a city or any place, and the security forces, they are after that fellow and they try to chase these terrorists, but this terrorist goes and hides in any building. So this is the terrorist and security forces, they surround that building throughout. So now these terrorists which have gone to one building and they are isolated and they are surrounded by. So now this cannot run it. Although initially security forces, they wanted to catch him, but they could not catch, and finally they surround him. Exactly same thing here also. So immune system, they were not able to eliminate, but now they isolate that foreign substance surrounding by these macrophages, and this is what is so called granuloma. I hope you understood the concept. Now we talk about the foreign particles. Definitely some foreign particle substance is there. Now this foreign substance can be infectious or it can be non-infectious also. Now in the infectious, this can be bacteria, fungus, and non-infectious like keratin and suture. So what I want to say, it could be infectious or non-infectious. Okay. So this one keyword, and second keyword is chronic inflammation. So there are only two keywords, chronic inflammation and infectious or non-infectious. Well, now we see the examples of each one of them. Just now I told you they are infectious or non-infectious. Infections. In the infection, then we talk about. Example are tuberculosis is the beyond doubt the best example. And one more thing, systemic fungal infection like histoplasmosis. They can also have this granuloma formation, but there is something trick. So the infection caused by TB and systemic fungi, they are usually caseation. Very, very important point. Again, this is a bottleneck. Most of the time when we say caseous necrosis, so everybody thinks, student think it is in TB. No, it is in TB, but most of students are not aware that it is there in systemic fungal infection like histoplasmosis. So even histoplasmosis also have a type of caseous necrosis and other systemic fungal infection also. I am sure this is additional knowledge for most of the students. Now we have been reading and talking about caseation, but what is the meaning of caseation? So caseation is due to lipid release from the cell wall of the dead pathogen, cell wall of the pathogen. And again, important point, it is dead pathogen. Well, terrorists are surrounded by the security forces. There are 10 terrorists. Now there is a fire exchange is there and some of the terrorists die. So here also some of the pathogens, they are dying. Now this dead pathogen, they will be releasing lipid, and that is so-called caseation. So now we learn that this will be there only in, of course, infectious agent. So now you understood that in non-infectious condition, there will be no caseation because this caseous material is coming from the dying of a pathogen. In non-infective condition like suture is a foreign particle, is not a live particle. So there is no question of getting any caseation. So if I go back to the previous slide, so now you understood that why we talk about caseation in the infectious and the non-infectious. So infectious will create caseation, non-infectious will create non-caseation. So let's talk about non-infectious causes. And one more thing, infectious causes when they are making caseation, we call as soft granuloma. Okay. So soft granuloma is the word we are using when they have a caseation. Well, non-infectious, they are definitely non-caseating. We understood the reason, what the basic pathophysiology, and we call as hard granuloma. There is no caseation. Well, one more thing, what has been taught is usually taught. One more reason why the word uses caseation. Because when you actually, when you take a biopsy material and you are wearing the gloves, you try to palpate this caseation. It looks like a cheesy material. That's why the word is also given as caseation. It is very soft, like a soft cheese. But this we call as non-granuloma. The causes are sarcoidosis, Crohn's disease, primary biliary. You can see the list, including Wegener's, subacute thyroiditis. One thing is very clear, all these are autoimmune disease. This is not infectious. Other disease like Church-Strauss disease, giant cell arteritis, Takaichu arteritis, foreign material like berylliosis, hypersensitivity pneumonitis. If you want to note it down, I'll again just display the slide for a few more seconds. Note it down if you want to note it down. Yeah. So now we talk about pathology, basic sciences, basic concept. About the morphology of granuloma. So it is a pale white nodule with or without central caseation. This is the most important, and that the meaning you know. Well, it is a well circumscribed in tissues. That is important. So same story, terrorists, a group of terrorists surrounded by these security forces. So they are totally well circumscribed, although it's a collection of macrophages, but they are very well, they are making a boundary line. So now you understood the meaning of well circumscribed. Okay, and now what are the cell type you get it? Of course, we are getting macrophage is the basic cell. So let us see what are the cells that we get in, especially I am talking about infectious granuloma, which is we see in tuberculosis. Okay. So first of all, we get activated macrophages. Yes, it is the any macrophage which is surrounding that foreign particle, maybe infectious or non-infectious, it is activated. Then only it has reached to that spot. Now, these activated macrophages are also known as epithelioid cell. This is confusing to most of students. What is this epithelioid cell? They are nothing but the activated macrophages is so-called epithelioid cell. In addition to these activated macrophage, so-called epithelioid cells, there are also mononuclear cells. So mononuclear cells, what are these cells? They are CD helper T cell. Okay. Now in CD helper T cell also, which variety? TH1. So-called memory cells are there. Okay, so-called memory cells. Memory cells, so in nutshell, if I have to give you summary of in this slide, so one is they are well circumscribed, appearance wise, yes. Cells, number one, epithelioid cell, which are nothing but activated macrophages. The second is CD4 cell, and that also TH1, so-called memory cells. So there are only 2 or 3 keywords to remember: epithelioid cells, helper T cell, and TH1, so-called memory T cell. Only 3 keywords to be remembered in this particular slide in the basic concept about granuloma. So now I show you lovely picture, then you will understand this you can say this is the so-called area of necrosis, and they are surrounded by these cells. They just see how well circumscribed this material is there. I hope now you will not forget beautiful a terrorist getting surrounded by the security force, the best example I can give to you. Okay, so we have a necrotic mass. The necrotic mass is NM, and they are surrounded by the activated macrophages. So we learned about epithelioid cell, but everybody knows that whenever we talk about granuloma, they always talk about multinucleate giant cell. But in the previous slide, I did mention to you regarding granuloma, but there was nothing mentioned about multinucleate giant cell. Let us see what is this. Oh, what happened? Multinucleate giant cell, which we all know, they are formed by fusion of epithelioid cell. Oh, now I understood. So, what is epithelioid cell? Macrophage, activated macrophage. And now, this one macrophage, this other macrophage, other macrophage, other macrophage. Now, these together, they fuse and they make multinucleate giant cell. So now the question is asked to you, which cell form the multinucleate giant cell? Fusion of epithelioid cell, which is nothing but activated macrophages. Now you can see 1, 2, 3, 4 and 1, now you can see single one. And now one more question from basic science. Now what is the thing which really unites this? Interleukin 4. Interleukin 4. Again, like we make a wall of the bricks, brick, brick, brick. We always have a cementing material like this. So this cementing material in this case is interleukin 4. So I hope, and interleukin 4 which is making combining, and that is making multinuclear giant cell. I hope things are very clear to you. Well, TNF alpha, again a very important point in the pathophysiology. What is this? We all know that this is very important to make for formation and maintenance of granulomas. Whether it is tuberculosis or fungal, where we are primarily getting caseating type of granuloma, this TNF alpha, which is a inflammatory marker, which is an inflammatory molecule, is very important to form and to maintain also. In fact, what happened? These TNF alpha and interferon gamma also, point to be noted, other molecules is interferon gamma, they recruit the cell for granuloma formation. Okay, well, now, so when we use TNF alpha drug like infliximab or etanercept, a huge amount of list is there, but only to give a few examples. So when we use TNF alpha, they cause breakdown of the granuloma, okay, which may result in dissemination of tuberculosis. This is a very, very important line. The clinical applied of this particular line, and this is the universal question you get in all the exam. So whenever you plan to prescribe any other TNF alpha, say infliximab, it is mandatory that the patient should be, you should fully investigate and you rule out tuberculosis or maybe hidden tuberculosis also. Because TB, it may really get reactivated, and that is the dangerous thing that we don't want it. So point to be noted, whenever you are prescribing TNF alpha, make sure that TB is ruled out. And now you understood the reason why they can break down the granuloma. And in other way around, if I have to tell you, oh, we have a group of terrorists, and these are the security forces. Yes. If you use TNF alpha neutralizing drug, they are going to break this security cordon. And now there is no security forces, this terrorist can very well spread around. There is no fear, the fear factor is gone. So now you understood why TNF alpha neutralizing drug are contraindicated in tuberculosis or patient, or why you should investigate for TB. So friends, we learned about only two things, two keywords, TNF alpha and gamma interferon. They recruit the granuloma cell formation. And number two, if you use TNF alpha, they are going to break down the granuloma. So TNF alpha or TNF alpha neutralizing drug, fair enough. Okay, now one more thing. Whenever we have this granuloma formation occur, let's talk about immune part of this granuloma formation. It is due to type 4 hypersensitivity. Okay? So in immunology, hypersensitivity reaction, it is the type 4. And what is, now let me tell you what is actually this type 4. It is a cell mediated response. We know very well we have type 1, 2, 3, okay. These other one, they are antibody mediated hypersensitivity reaction. But type 4 is the exception where antibodies are not involved. So it is a cell mediated type of immunity, the reason you have seen. So there is no involvement of antibodies. So that's a basic concept about type 4 hypersensitivity reaction. So in this slide, there are only one thing is type 4 hypersensitivity, and there are no antibodies, is just cell mediated. Only two keywords, 1 and 2. Now we actually come to the topic of sarcoidosis. So till now I was just talking to you regarding basic about granuloma. So now again we go to the definition. We know that it is a non-infectious. That point is already clear to you. We also know it is a non-caseating, the point we discuss. But now additional point, it's a granulomatous disease we discuss. And it is a multi-system. The only new keyword what you learned here is multi-system. Multi-system is it is not confined to one organ. It involves many organ system are involved. Which many organ system that I am going to discuss in a few minutes only. Well, one of the key factor that they do, of course they do lot of things, but they can lead to chronic interstitial fibrosis in the lungs. Of course, okay, that what happen in the terminal stages. Many more things happen, but it is just an idea of what they can do. And when you are seeing this in interstitial fibrosis, it's very clear that lungs are one of the main target that are involved. What they do, we'll discuss very soon. So it's a type of interstitial lung fibrosis or interstitial lung disease, as I just mentioned you, or they're going to cause fibrosis. Now extra point, you have seen 100 cases of interstitial lung disease. ILD stands for interstitial lung disease. There are large number of conditions which can produce ILD, but you will be surprised to know that sarcoidosis constitutes about 25%, is a huge percentage. And remember, again repetition second time, there are n number of things which can lead to lung fibrosis. But 25% share is of sarcoidosis, very important. Common in black ladies and the non-smoker, again something very amazing. Usually the lung disease are more common in smoker, but this is one exception, more common in non-smoker, okay. Well, more common in women than the men, 20 to 39 is the peak age. So now if I have to give you a one-line summary of these three, middle-aged African American female is the summary of what you got to remember in this, that's all. The only thing you got to remember, and it can lead to ILD. So ILD and the middle-aged African American female, the two keywords to remember in this particular slide. After that, now let's talk about pathogenesis. We learned a bit about immune, now we'll talk more about the immune process that is especially valid for sarcoidosis. So what is there that in this case MHC, so-called major histocompatibility complex, which we traditionally or very easily write as MHC. So there may be even non-MHC gene also. So whatever MHC or non, which chromosome involved? Chromosome 6, this you should know. So chromosome 6 is the first keyword to be remembered in this particular slide. Okay, so now we have read the basic pathophysiology. We get CD4 Th cell, which we know they are memory cell, okay. Now these memory cell, they interact with the unknown airborne antigen. It is said that perhaps it is due to all antigen which is airborne. Well, this could be mold, pesticide or mycobacterial CAG protein. Well, this point need more discussion. Why it is a airborne antigen? The reason being lungs is the most common site which is involved. Lung involvement may be as high as 90 to 95%. And the one antigen, any antigen which can reach the lung is by, no need to say, by airborne. That's why it is postulated any antigen unknown, we don't know, it's nothing proven. This could be all these what I talked. Even in mycobacterium also they talk about CAT-G protein is the one. And remember, tuberculosis is a very important cause of granuloma formation. Of course, granuloma especially for this caseating. But here I am talking about any reason why granuloma formation occurs. Remember, this line is valid for both infectious and non-infectious. Okay. Well, now these, once they interact with the antigen, they release cytokines and they cause formation of non-caseating granuloma in sarcoidosis definitely. So these cytokines will lead to non-caseating. Why non-caseating? There is no live material, and caseation is made by the lipid released from the dead pathogens. Well, any granulomatous disease, especially sarcoidosis, which can be caused by n number of conditions, can lead to non-caseating granuloma. So diagnosis is also always by exclusion. Exclusion means you have investigated, you have the patient, you have seen the patient, you have examined the clinically, and you rule out other granulomatous diseases. That's very important. That's why the diagnosis become little late, because it's not an immediate diagnosis, it's more of a diagnosis by exclusion. So friends, the key word is chromosome 6, airborne antigen, and third is diagnosis of exclusion. So there are only 3 keywords that you got to remember in this particular slide. So now, having learned the basic problem, what happened, now let's talk about sarcoidosis. One thing we have read it is a multi-system disease. This point we already know. So let us see. And we also know that lung is the most common site, reason being perhaps it is due to airborne antigen. So with this background, so who are the patients? Young black women, the point I mentioned to you, and they usually come with a non-specific complaints. Majority of time no symptom, they are just diagnosed incidentally. But otherwise, a young black lady come to you, non-specific fever, weight loss, malaise. Point to be noted, they are very non-specific. They can occur in so many conditions, right? Fever, malaise. The patient may be having long time, maybe patient come to you for 1 week, you will always think about the was of viral infection. Anyway, you cannot diagnose on day 1 or day 2. Well, after that, now the time has passed. Remember, it is a type of chronic disease. Again, recall the first slide is a type of chronic inflammation, it's not a acute illness. That's why that by the time patient come to you, already is in the chronic phase. But don't forget, every chronic start with the acute. That is a standard line. But however, in the acute stage, the non-specific feature, and now we presume that patient has been having the problem for a long time. So lung disease is there in 90%. Now you are convinced that it may be due to airborne antigen. So they say it's a primary target. That's the most important starting point, or you can say engine of a train is lungs. Okay. Well, now these granuloma, which no need to say they are non-caseating, they are in the interstitium of the lungs, maybe mediastinum or in the hilar lymph node. Out of these, the most important is hilar lymph node. But point to be noted, they can be in the interstitium also. It has a special meaning. What is that meaning? I am going to discuss in a minute only. Mediastinal also again has a meaning. Now, granuloma contain multinucleate giant cell. I don't think I need to repeat why and how they are made by fusion of the activated macrophages, so-called epithelioid cells. Yeah. Now, something extra. Again, beautiful question for the basic sciences, pathology. Now, these they also contain certain granuloma, they also contain certain inclusion body, so-called Schumann body, an asteroid body. These I will be talking to you in detail. So they contain certain inclusion body also. So somebody asks you what are the constituent of non-caseating granuloma, multinuclear giant cell, everybody knows. There are certain inclusion body, and ultimately in the due course of time in the pathology, lung fibrosis can occur. The point I mentioned to you that lung, it is a 25% case causes of interstitial lung disease, which are due to interstitial lung fibrosis, are due to sarcoidosis. So interstitial lung disease, ILD, and of course all ILD, they lead to a type of restrictive airway disease. Restrictive airway disease. Now, if I tell you the spirometry of a case of restrictive lung disease, FEV1 is reduced, FVC is reduced highly. So that's why FEV1 FVC ratio may be normal or increase. Okay, ratio may be normal or increase. This is what we get in spirometry. Pleura may be involved in 15%, and pleural effusion is seen in just about 10 to 15% cases. That means pleural effusion is not a common finding. This is in contrast to tuberculosis, where pleural effusion is a common finding. So in this is uncommon. Cavitation is rare. Remember, cavitation, and these two are very, very important in tuberculosis because they are the caseating type of granuloma. So we have seen the pathology of the lung involvement is there. Of course, there is a radiology also, which I will be coming to you little later on. So now, what lung symptom will be there? Progressive dyspnea is the most common symptom. In fact, this is the progressive dyspnea, especially on exertion, is a finding not only in case of sarcoidosis. This is true for any interstitial lung disease. ILD, interstitial lung disease due to lung fibrosis, is a feature of all ILDs. Dry cough, point to be noted, dry cough, that means no sputum. No sputum. Sputum is there in infective pathology, not in non-infective pathology. Chest pain can be there, but again non-specific. So dyspnea and dry cough are the only two things that you got to remember in this particular slide. Well, lymph node. Bilateral hilar lymph node. This is the hallmark of sarcoidosis. Very, very important. Although it is a part of lungs, but it is usually discussed separately, because this is one of the most important finding in sarcoidosis. In fact, majority of time when we really think about the patient has chest X-ray with bilateral hilar lymphadenopathy in the lungs, of course the possibility comes of sarcoidosis, but other possibilities are also there. What are these? But I am going to discuss soon. In addition to that, these patients can have lacrimal gland enlargement, and parotid gland enlargement is a feature. Now, there is something important. So, the keyword are, number one keyword, second is lacrimal and parotid, again have a meaning in investigation also. And what is that? We will talk later on. So, I talked to you regarding in the previous slide regarding bilateral hilar adenopathy. That means in the chest X-ray, when you see, you find in both the hilum of the lungs, the lymph node are enlarged. Are they specific to sarcoidosis? No. They can occur in many other conditions also, like infection, like tuberculosis. In fact, it is one of the most common manifestation, one of the most common cause of bilateral lymph node enlargement. Malignancy, lymphomas, Hodgkin lymphoma or non-Hodgkin lymphoma. Other cancer can be there, but don't forget lymphomas, TB. Organic dust, silicosis, berylliosis, this is very, very important. And sarcoidosis. So friend, in this slide, don't forget 1, 2, 3 and 4. They are the 4 most important causes of bilateral hilar lymphadenopathy. Now, so we learned about what can happen in the lungs. So now let us see what are the skin lesions that we can see in a case of sarcoidosis. Nodular lesion can be there. And no need to say they will be containing granulomas definitely. And that again, one more important point, if the skin lesions are there, then it is very easy to take a biopsy to diagnose. This point again I'll take when I'll talk about investigation, but right now do remember that skin in this lesion can be there, can be. Nodular lesion can be there, okay. In addition, there can be lupus pernio, very important point. This is a universal question. What do you mean by lupus pernio? Violet color rash over the nose and cheek. Violet color, nose and cheeks. They are so called lupus pernio. Look into this. Look into this. Now you will not forget. In the face or around the ear. So we are getting purple, blue, shiny, swollen lesion on the nose, cheek, lips, ears. So if you look nose, cheek, lips and ear by and large, okay. Well, now the COVID period going on, or all of us are wearing the mask, and if I ask you, mask cover which area? Well, nose, ear, cheeks. So now again I can make a subject easy. Somebody asked you which area lupus pernio is seen, you can say, oh, area covered by the mask. What other area is? Nose, cheek, lips and ears. Yeah. So you can, so things are made very easy for you, right sir? So they are the lupus pernio. They are really purplish blue, shiny. This you can see, lovely color is there. Yeah, it is really purple color is there. Erythema nodosum is painful nodule, a very commonly asked question in the exam. It is a, now the true about is painful, painless, etc. They are painful. Nodule in the lower extremities. It usually, they say, is the inflammation of the subcutaneous fat, what they talk about. Well, it is a painful nodule. And not, remember, it is not only seen in sarcoidosis, it is seen in many other conditions like tuberculosis also it is seen, right? So it's not a specific only for sarcoidosis. So now this you can see usually in the lower limb, okay. Paniculitis, okay. It's a group of conditions that cause painful bumps or nodule to form under the legs, in the legs. They are painful, and they are, that means they are mainly seen in the subcutaneous fat area. This inflammatory marker, this is seen. But again, they are painful bumps that we see in these patients of sarcoidosis, okay. So with this we move on to the next is this a classical thing regarding paniculitis, okay. Eye lesion, they are very important. There are 5 or 6 mentioned in this. So there can be uveitis, that is inflammation of the uvea. Conjunctivitis, that is inflammation of the conjunctiva. Keratoconjunctivitis sicca, that means this may make it dry eyes. And that can lead to blurry vision also, glaucoma and corneal opacities are there. Definitely if the corneal opacity are there, glaucoma, all these they will make a blurry vision. Blurry vision. Now out of this, this is single most important. Rest you forget, I don't mind. But if you forget this, this is not expected. Don't forget uveitis. Single most important thing in the exam also, when they talk about uvea only. Now I have a question only for the student to answer. Write down the answer. Here we are talking about corneal opacities. Okay. Now tell me any drug you know of where there is a side effect of the drug as corneal opacities. Write down. Question only for student. You get 20 seconds to think and write. And those of my friends who are watching, who will be watching as a recorded video, you can stop the video, write down the answer. Well, corneal opacity is seen in amiodarone. Okay. The drug corneal opacities are also seen in chronic kidney failure, CRF, chronic renal failure, so-called end-stage renal disease. Corneal opacities are seen in, but that is not a drug. It is all due to disease itself. So eye lesions, very, very important. This you can see uveitis, lovely, and there may be, patient may have hypopion also. Hypopion is nothing but accumulation of pus in the anterior chamber, or there may be conjunctival redness may be there in sarcoidosis. So patient can have uveitis, hypopion, or conjunctivitis sicca also. Now liver, well, it can lead to granulomatous hepatitis, and in fact it's the most common cause of non-infectious cause of hepatitis, granulomatous hepatitis. Okay, point to be noted. Now in addition to that, there are certain other organ system involved like CNS involvement, Bell's palsy. That is seventh nerve palsy, the most common cranial nerve involvement in sarcoidosis. Well, what happened in sarcoidosis, in Bell's palsy? You can see the face is turned toward the normal side. There is a both ipsilateral upper and lower part face is involved. It's a type of lower motor neuron palsy. Okay, this is the Bell's palsy. There can be meningitis. Of course, it will be non-infective meningitis. There can be peripheral neuropathy, non-specific. But out of single key word to remember is Bell's palsy. CNS involvement, this can lead to restrictive cardiomyopathy. Easy to remember. Why? Because it is causing fibrosis in the lungs. It can also lead to, so that lead to type of restrictive airway disease. It can also lead to type of restrictive cardiomyopathy. And due to same reason, there can be arrhythmias that are again non-specific, and they can do cor pulmonale, secondary to lung disease. Okay. Arthritis may occur up to 30 to 50% cases, a huge percentage. Joint involvement can be there. It is usually polyarthritis, multiple joints are involved. 5 or more than 5 joint involvement is what we call as polyarthritis. There can be muscle pain, myalgia, they are again non-specific. So what all to remember, one is restrictive cardiomyopathy is one keyword, and second is polyarthritis. There are only 2 keywords that you got to remember in this particular slide. Restrictive cardiomyopathy is the number 1 and number 2 is polyarthritis. That's all. This is what you have to remember in this slide. Kidney involvement, it can be due to tubulointerstitial disease. It's a chronic, not acute, chronic tubulointerstitial disease is there, right? So when we know that when tubulointerstitial disease is there, so what is the main problem? There will be impaired concentrating ability. When the tubulointerstitial disease, the patient has loss of concentration ability is lost, right? So it is a chronic condition. Chronic tubulointerstitial disease is there, right? So there can be nephrocalcinosis, stone formation can be there. Why this happen? This is a special reason which I am going to discuss in the coming slides. So it may even involve the hypothalamic pituitary system also. So that can lead to a cause of central diabetes insipidus. That means the body will not, so central means the body is not secreting ADH, the central diabetes insipidus. And there can be granuloma formation also, especially in the bone marrow and the spleen, and that can lead to a type of, the reason why these patients tend to have leukopenia is a feature in this patient. Leukopenia occurs in this patient, right? So friend, the key word to be remembered in this particular slide are nephrocalcinosis, central diabetes insipidus and leukopenia. There are only 3 keywords to be remembered in this particular slide. Well, this is important. Uveitis fever is a rare manifestation and patient has uveitis. Now you remember when I discuss eye involvement, there are 6 or 7 things were there, but I said don't forget uveitis. So now you can see in uveitis, the name itself suggests uveitis means there is involvement of uvea and there is involvement of parotid. Okay, parotid gland is there. So with this, in addition to uveitis, as the name suggests, there is swelling of the parotid gland also. The parotid gland swelling, that's why together they constitute as what? They constitute as uveitis fever. And of course, the fever is there, it has to be. So friends, there will be fever also, uveitis also, and enlargement of parotid gland also, chronic fever is there, and so uveitis fever, 3 things. And in some cases there may be Bell's palsy. The point I mentioned that Bell's palsy is a very important feature of sarcoidosis. So uveitis fever is also known as Hereford syndrome, the other name for this. You can see there is fever, of course, which there swelling of the parotid gland, you can see swelling in the parotid gland, you can see. Little bit of uveitis, not very obvious, but parotid gland enlargement you can definitely see in this patient. We have one more acute sarcoidosis. Point to be noted. We talked about sarcoidosis as a chronic, but it may have, in medical science, there is nothing like absolute. We have a term called Lofgren syndrome. Lofgren syndrome, which is usually termed as acute sarcoidosis. Erythema nodosum, polyarthralgia and bilateral hilar adenopathy is there. So if I have to show you a picture, now you can see this is hilar adenopathy, this entity, polyarthralgia, okay. Usually ankle joint are painful, but there may be other also. The acute pain is there. Acute pain is there. And erythema nodosum, you can see erythema nodosum. So friends, we are getting classical finding of hilar adenopathy, acute joint pains and the erythema nodosum. Now, discussion of sarcoidosis is incomplete unless we talk about calcium metabolism. This is a very important point. So what happened? I think this is a universal question. It is asked in all the exam. In my opinion, it is one of the most important points That you should remember in sarcoidosis, hypercalcemia. But why hypercalcemia? So there occur hypercalcemia and there occur hypercalciuria also. Both are happening. That means the calcium level is very, very high, and that is causing hypercalciuria. Definitely if the calcium level goes high in the blood, that is bound to happen, bound to cause hypercalciuria. That means large amount of calcium will go out of the blood in the urine, so-called hypercalciuria will be there. Okay, yeah, we understood. But what is the reason? Usual question is about mechanism, why happen. This increased vitamin D production. So these granuloma, remember whether it is granuloma means whether it is caseating or non-caseating, whatever reason it may be. They produce large amount of vitamin D by the granuloma itself. So granuloma itself act like a factory, so-called in-house production of vitamin D. And excess of vitamin D is there, and that lead to increased calcium reabsorption. But why? How come? This due to increased alpha-1 hydroxylase. So activated macrophages, they secrete alpha-1 hydroxylase, and that lead to what? Increased amount of vitamin D, or so-called hypercalcemia. So it is the activated macrophages which are going to cause increased vitamin D production is there. Yeah. Okay. So increased alpha-1 hydroxylase activity is there. So now in the vitamin D level is increased. So this lead to increased calcium reabsorption in the GIT definitely, and bone resorption. Secondly, to high amount of vitamin D, and that lead to increased calcium, but PTH level is suppressed. Very, very important point. So what lab finding? Increased calcium, increased phosphate, reduced PTH, normal ALP, ALP will be normal. There is only reabsorption is there. Only reabsorption is there. There is no deposition. That's why ALP. So this is the single most important line in sarcoidosis. Cannot afford to forget this line. Repeating second time, increased calcium, increased phosphate, reduced PTH, and normal ALP that we get in this patient. So other lab finding, ESR is raised, leukopenia, you know the reason, because bone marrow may be involved. Immunoglobulins are increased. There is increased level of angiotensin converting enzyme, so-called ACE. It may be seen in as high as a 60% cases, a fairly high percentage. It's a non-specific finding, because this is increased in other granulomatous disease also. Point to be noted that the calcium is increased in all granulomatous disease. The ACE level also increase in granulomatous diseases. Again, they are by macrophages. Well, even vitamin D was by macrophages, courtesy again in-house production of ACE, and it is a marker of severity and activity of disease. ACE level are marker of activity. Why? Because they are being made by the activated macrophages, which are the key cells in sarcoidosis. So as I told you, ACE level are non-specific. They are increased in so many conditions. Any of the granulomatous condition it can be increased, like sarcoidosis, asbestosis, leprosy. If you look into the list, all these are the granulomatous disease or condition which can lead to granuloma formation. The list is already with you. So I just included them in the list just to make sure that ACE level are increased in all granulomatous diseases. Other finding is polyclonal gammopathy. I told you immunoglobulin are increased, and they have a cutaneous energy. So in these patients, Montus test is negative. MON2 test is negative. Okay, why? Because there is consumption of CD4 cell and they are lost. That's why in these patients, the reason given is that why MON2 test is negative, but CD4 cell has been used in making granuloma and loss of cell in the alveolar secretion also. So by and large in these patients, CD4 cell the count get low. That's why they are. That's why they are. Remember, CD4 cell are being secreted in the alveolar secretion also. Chest X-ray is always the best initial test. In fact, rather other way around. At times, this disease is diagnosed by chest X-ray only, both way, vice versa. Enlarged hilar lymph node I mentioned, and they are known as potato nodes. A name has been given, a fancy name has been given, potato nodes. There can be reticulonodular densities. Why? There may be lung fibrosis. So in addition to that, well, there can be only hilar adenopathy or there may be additional in the parenchyma also. It has a special meaning. What meaning I am going to discuss in the coming slide. So you can see these hilar adenopathies there. But just to remind you, this can happen in so many conditions. The list is already with you. Okay, but sarcoidosis is a feature, it's a finding. But remember, if you get X-ray like this, should we sarcoidosis the first line investigate some first line diagnosis? No, sarcoidosis is never the first line. Well, depending on it may be from the maybe in the very well developed country, the lymphoma should be the first choice. But a patient is coming from any subcontinent country or African country, then tuberculosis should be the first choice, depending on. But sarcoidosis is never the first or second. Now we discuss about how we really classify chest X-ray finding. Well, stage 0 normal chest X-ray. You are getting one patient with fever and all these things, and you have seen chest X-ray is normal. So we call it stage 0. Point to be noted, he may have sarcoidosis with normal chest X-ray. Stage 1 hilar or mediastinal enlargement only, and in fact this is the one which is considered and taught as the most common finding, usually talk about, but it's not the only finding, there are other findings. Stage 2 hilar and parenchyma both, that means this is the lung, okay, lungs, there may be hilar adenopathy. So this is the lungs. First thing is hilar adenopathy. Stage 2 hilar and parenchymal involvement is there. Stage 3 only parenchyma. Stage 4 lung fibrosis, right? Stage 1 hilar adenopathy. Stage 2 hilar and parenchyma. Stage 3 only parenchyma. Stage 4 is lung fibrosis, which I told you is a common cause of interstitial lung diseases. Okay, so now let me show you stage 1. Stage 1 you can see hilar adenopathy. Stage 2 hilar adenopathy and there is involvement of parenchyma also. Stage 3 this involvement of only parenchyma, opacities are seen. Stage 4 you can see diffuse lung fibrosis is occurring in these patients. Okay, lung fibrosis. This you should know. Tissue biopsy, in fact, it's the most accurate way to diagnose. We get non-caseating granuloma, the point I mentioned, you can take from lung, liver, lymph node, skin nodule. You remember what I mentioned about 6 skin nodules. Okay, and it's very easy to take a biopsy from skin, no doubt, as compared to other. Of course, lymph node also, lacrimal gland also, but of course, skin is the most easy way. So you can see a lovely granulation tissue surrounded by the necrotic mass with the macrophages. Now, little bit again of pathology. We discussed that we are getting epithelioid cells, activated macrophages, yes. We get multinucleate giant cells, yes. Now, this multinucleate giant cell may contain certain inclusion body. What are these? That's why I have to repeat this just to tell you more. What are the multinucleate joint cell which were formed by the fusion of the epithelioid cell or macrophages? They contain inclusion body. What are these? Schum's body. What are these? They are laminated calcium concretions. And now I don't need to tell you that why these concretions are being made. Remember, this is being made in the cell, which itself is making a large amount of vitamin D. Now you can look into this. Schumann bodies, concretions, you can see lovely multinucleate giant cell. You can see lots of nuclei are there, and in addition you are getting concretion, calcium, so-called what? Schumann bodies, calcium concretion. Second is asteroid body. They are stellate inclusion. Initially they were thinking this is due to perhaps cytoskeleton element, may consist of mainly vimentin. Previous one were calcium, this is vimentin, but the new concept they say, the newer they are not cytoskeleton, they are bilateral lipid, they are composed of lipid. Anyway, so in the two keywords, what are they made of? Either vimentin or maybe lipid. The older one, if you look into vimentin or lipid, both are given. So you can say, so asteroid are vimentin or lipid, that's all. Now you can, oh lovely, asteroid, the name itself suggests asteroid body. Now you will not forget. We have a residual body, there is one more. It is a cytoplasmic vacuole. It contains leftover product of digestion. And now these vacuoles, they fuse with the lysosome and they make residual bodies. So friend, in sarcoidosis, we get Schumann body, calcium concretion, we get asteroid body, which are vimentin or bilipid layer, or the residual body which contain the leftover food, sarcoidosis, inclusion body. The residual body you can see, residual bodies. Now we do bronchoalveolar lavage. There are increased lymphocyte in active disease. You know how the bronchoalveolar lavage is done. What they do, they put a endoscope via nose and they go to the lungs. And once they reach the lung and they try to take aspiration, what we call as bronchoalveolar lavage. And now in this, once they have taken the aspiration, they look for CD4, CD8 cell. And if the ratio of this in the BAL is more than 3.5, I can say CD4 cell will be highly increased as compared to CD8. That's why the ratio will be more than 3.5. This is highly suggestive of active sarcoidosis. Well, now again I have a question for the student to answer. Question only for student. You have learned the basic pathophysiology very nicely. Can you give me the reason why this ratio is there? Write down, you get 20 seconds to think and answer why this ratio is there. And I already have given the answer to this question. I will repolish your knowledge. Quickly write down. Well, answer is, recall when I said the Montus test is negative, right? The reason what I get, they have negative energy. And that time I told you in these patients CD4 cells are reduced in the blood, okay, or whatever you can say. Remember, in the blood the CD4 cell they are not changed, but these in the skin they are not there. Why? Because majority of time these CD4 cells have been consumed in making a granuloma in a localized tissue, and CD4 cells are secreted into the alveoli. So now these CD4 cells, they have been diverted to the secretion in the lungs, and that's why when we take a bronchoalveolar lavage, CD4 cell count is very high. Remember, this change is in the ball, not in the blood, not in the blood. I hope you got an answer, right? So tubercle test is negative, the point I already mentioned to you. ECG may show some arrhythmias in secondary to restrictive cardiomyopathy, non-specific finding, but this is frequently asked. Montus test is negative. Lung function test, restrictive lung disease, the ratio I already told you, I explained to you. FEV1, FEC ratio is normal, and since they have a lung fibrosis, they will get restrictive lung disease, and impaired gas transfusion means diffusion will be reduced. This is a feature of all restrictive airway disease. QIM test is positive. What is QIM test? It is just like Montus test. In Montus test, we use tuberculin. Okay, it's a tuberculin test, but here we use the antigen specific too. It is just like SCAMES, subcutaneous test, just like tuberculin test, specially mentioned for sarcoidosis, but it is not done. It's a obsolete or outdated test. We don't do, but you should know there is something called QIM test. Ultrasound may show hepatosplenomegaly, again non-specific, maybe some stone, but they are not in particular for the sarcoidosis, non-specific. Bones may show punch out lesion, internal pharynx in particular, very, very important point. You can see point out lesion. Okay, why? Vitamin D level is increased and they lead to resorption of the calcium. That's why calcium and phosphate level is increased, and particularly you get this punch out lesion in terminal phalanx. CT MRI can assess the severity of pulmonary disease, but they are adding to diagnosis, but they are not giving you accurate tests. You must do the eye examination to rule out any eye disease. Again, is examination finding. They are just going to see the eye involvement is there or not. Now, gallium scan, this is the one which may help you in diagnosis. What is this? It supports the diagnosis. If you get increased activity in parotid and lacrimal gland, remember I told you in the examination finding there can be enlarged lacrimal or parotid gland. So when we use gallium scan, there is increased uptake by parotid or lacrimal gland, we get panda sign. Maybe right paratracheal and the left hilar node, this is called lambda sign. Look into this. Look into this. Okay. So we are getting in the parotid and in the lacrimal gland, yeah, and we are getting enlargement in the tracheal glands, and this is so called panda sign. Panda sign, okay, lambda sign. So remember, P for panda, P for parotid, right paratracheal or the left hilar area increase uptake is lambda sign. You may or may not remember, but don't forget gallium scan is the one which really shows the increased activity. So we got a patient of sarcoidosis. Now we want to treat the patient. How to treat? The patient has only bilateral hyaluronopathy. They usually resolve of their own. But remember, if the patient has only come with BHL, bilateral hyaluron lymphadenopathy, there is no other problem. Can you leave it? No way, no way. You have to, these patients, you have to go for lymph node biopsy or aspiration. This you have to do under CT guided. Mandatory. If you remember, again recall, sarcoidosis is a diagnosis of exclusion. This can highlight neuropathy may occur in TB also, lymphoma also. You have done all the gadget or tests relevant to TB and lymphoma and other thing, nothing. Then of course no, in this case you have to, unless you are sure about it, you have to do. In that case you are getting non-caseating granuloma and not fitting into any other category. You think about sarcoidosis, but point to be noted, the high calcium level, high ACE level will be helping you in diagnosing. So bilateral adenopathy, they resolve of their own. Usually they don't need treatment. Otherwise, remember, hyaluron adenopathy, they usually resolve of own. Otherwise also sarcoidosis, it got resolved. In such cases, you treat the basic UVI, you have to treat uveitis. You can't ignore uveitis, you can't, otherwise patient will lose the eyesight. Otherwise, if you want to give any drug in a sarcoidosis case, drug of choice is corticosteroid is the drug of choice. Hydroxychloroquine is used when the skin involvement is there. In fact, hydroxychloroquine is also used when skin involvement in SLE also. Okay. And here also skin involved, use hydroxychloroquine. NSAID if pains are there. In some cases, of course, majority of the time they respond very well to steroid, but in some cases, we have to use immunosuppression like methotrexate, cyclosporin. Leflunomide is the newer anti, it is immunosuppression, and thalidomide. Thalidomide is the one drug which has led to the biggest tragedy in medical profession as a side effect. Phacomelia. Just to tell you history of this drug, in somewhere in mid 1940s, a drug thalidomide was developed. It was used as a sedative drug. And in those days, whichever pregnant lady, especially in the first timer, said they took this drug, they gave birth to children. They were having no, very small limbs. Small limbs, very small limbs were there. What we call as phacomelia. It's the biggest human tragedy, and this drug went into disrepute. Total out of scene, remember, in mid 40s, 1940s, and now it is 2021, after almost, you can say 70 years down the line, 60, 70 years later, this again has come up. Wonderful immunosuppressive drug being used in so many conditions. But this drug is absolutely contraindicated in pregnancy. No need to say. Well, in some cases we can even use tumor necrosis factor inhibitor also, TNF alpha inhibitor. And I don't need to repeat, whenever we are using this, you have to make sure that there is no TB or no hidden TB. Well, usually they recover very well. The mortality rate is only 5%, particularly in the black American people. Otherwise, usually they have a good outcome. So a quick recap of the last minute revision point. It is a non-caseating granulomatous disease. Granuloma is a collection of the macrophages. Sarcoidosis is asymptomatic. Dyspnea is the most common. In the skin there can be erythema nodosum and lupus pernio. Bell's palsy can be there. Pituitary dysfunction can lead to cranial diabetes insipidus. uveitis, hypercalcemia, hypercalciuria, raised level of ACE, but that can happen in any gallbladder disease, chest X-ray, hilar adenopathy, parenchymal involvement may be there. Pleural effusion is uncommon, seen only in 10 to 15% cases. Most accurate test is biopsy, and ratio of CD4 and 8 cell more than 3.5 in bronchoalveolar lavage is highly suggestive of active disease. Tuberculin test is negative, restrictive lung disease, the type of spirometry we get it. Quim test is negative. Panda sign and lambda sign are seen in gallium scan, and steroid is the drug of choice in these patients. Thank you very much. God bless all of you.